Good afternoon, everyone, or wherever you are in the world. I guess it's really happy Tuesday, 2/22/22 on Palindrome Week. I'm Laurel Steimanoff. I would like to welcome you to this town hall, where we will be presenting the latest on oral antivirals for COVID-19. Our facilitator today is Dr. Joe Toscano. I think many of you are familiar with him. He is an urgent care fellow who also serves as the UCA clinical content advisor. Additionally, Dr. Toscano is a College of Urgent Care Medicine board member, a former UCA board member, and we're pleased that he's also chairing the college's Advancing the Specialty Task Force. He has a medical degree from Duke University School of Medicine. He trained as internal medicine at the Naval Hospital in San Diego, and after a tour of the duty in the Navy in submarine and diving medicine, he's worked in emergency medicine and urgent care for over 30 years. So with that, I'll turn this over to, I apologize, just a few housekeeping items as well before we begin. You can ask questions that we will be attending to at the end of the presentation. It would help if you put them in the Q&A section of the Zoom session at the bottom of your screen. And also, we just want you to know this webinar is being recorded. We will post it afterwards. The recording usually takes about a day to do that, and we'll be posting the slides as well. So with that, I will turn it over to Dr. Toscano. Thank you.
Thank you, Laurel. Well, I'm happy to be here, happy to moderate, and very happy to introduce Dr. Derek Eisnor. He is an emergency and critical care physician with over 25 years of experience across a broad range of practice environments, both in the US and abroad. He currently serves as medical officer in the Department of Health and Human Services, Assistant Secretary of Preparedness and Responses, Biomedical Advanced Research and Development Authority, or BARDA. This is in the Division of Clinical Development. He's also lead for the COVID-19 Federal Response Team, responsible for the federal government's allocation and distribution of COVID-19 therapeutics. He earned his medical doctorate at the Albany Medical College and has since received credentials in general surgery from Baylor College of Medicine, as well as in emergency medicine from the University of Florida, and in medical toxicology from the Centers for Disease Control and Prevention, as well as Emory University. Derek, you want to take it away?
Appreciate that. Thank you, Dr. Toscano. And just to clarify, that was an internship in general surgery when I was still trying to figure out what I wanted to be. So anyway, I want to thank everyone who's taken time out of their busy schedules to be here today. I'd also like to thank the meeting organizers for the opportunity to speak with you and provide some critical information and hopefully answer questions with a good Q&A session. So let's dive right in. Next slide, please. So equity is central to HHS and the US government's planning in terms of distribution of all of our therapeutics. As many of you are aware, HHS some time ago had surveyed and gotten positive feedback from roughly 200 HRSA-funded federally qualified health centers, and they exist in all 50 states, to be part of our direct allocation for oral antiviral products. So roughly 15% of all of the regular allocations go to these HRSA-funded centers to serve vulnerable populations. We are also working on other agendas to try to, no worries, we are trying to work on other agendas to bring forth other efficient mechanisms to enhance access. Currently working on a test to treat option to really rapidly link positive COVID testing to therapeutic options, and looking at a pilot program with participating pharmacies to make that happen, as well as a specific channel for long-term care facilities and their supporting pharmacies to really make sure that access is available for oral antivirals, again, to these very vulnerable communities. Apologies. Can you guys hear me?
Yes.
Okay.
Yes. Yep.
Okay. So next slide, please. Just a brief overview in terms of how we distribute products. So in terms of the states have weekly, we push out information in terms of what their allocation numbers will be. Some of our products are still on a pro rata based distribution scheme. Others are on a disease-based distribution scheme, and this takes into account the 7-day moving average of total number of cases versus the nation's total as a percentage. And also, we also look at the number of 7-day average hospitalizations as well. And so the product moves, after inspection, moves from USG facilities to Amerisource Bergen, who is the primary distributor for our therapeutics. From there, we have a computer ordering system, so all orders go through our HPOP system. So once the jurisdictions, and prior to this, the jurisdictions have already identified sites within their purview that can receive product and the specific types of product they receive. So not every site would receive all products. There are some that are best suited for oral products. Some are set up specifically as infusion centers to receive MABs. And so those jurisdictions, once they have those numbers, they determine how much of each product will go to those sites. Again, 15% of total allocations will go through a federal channel for the FQHCs managed under HRSA. And so once the jurisdictions determine where a product is going, it is shipped out from ABC. It's a turnaround time of roughly 2 to 3 days for a product to get on site. We also have federal pharmacy partners. So that's kind of was set up early as the easy button for jurisdictions. So for jurisdictions that wanted to utilize and we have roughly 19 of the largest pharmacies that have signed up with our federal pharmacy partner program. So looking at pharmacies like Walgreens, Walmart, CVS, Publix, they have a robust distribution network. And so states can decide that they want to push product through that and how much of that product they want to do versus also allocating to specific individual sites, which is clearly key for rural areas where there may be limited access. Next slide, please. This is just an example of our allocation calendar that we try to push out as far out as possible, understanding that we are currently pushing out product as quickly as we get it in. So we're really not sitting on product. Also understanding that of the many levels of equity that we have to maintain, temporal equity is also a key priority. And so trying to push out as much product as possible, as quickly as possible to meet this recent surge. And at the same time, making sure that we're not empty-handed when it comes to the next week. Also, you'll notice on this calendar, we previously were on a 2-week cycle for the oral antivirals. And in March, we are moving to a weekly cycle so that all the products will be aligned on a weekly cycle. And you'll also notice there's been a slight drop in terms of molnupiravir allocations. And keep in mind, we're also going to weekly versus 2 weekly. So that's where you'll see that drop in number as well. But even based on the 2 weekly or a monthly allocation, in terms of total numbers, there's a slight drop just in case in terms of utilization. So obviously, I think most would understand that utilization of molnupiravir is lagging significantly behind Paxlovid. For many reasons, not the least of which is where it ranks in terms of specific language reflected in the FDA fact sheet. Next slide, please. I know this talk is focused on oral antivirals. I do want to touch on remdesivir. I do understand that there are many logistical challenges with utilizing the 3-day infusion that was put forth in the Pine Tree trial. But again, based on its efficacy, based on its numbers from Pine Tree that put it on par with our best monoclonal antibodies in terms of reducing hospitalization in those at-risk populations, I do feel it's necessary to touch on it. So the FDA has approved use in the outpatient setting. They also have put forth an EUA for use in the outpatient setting in pediatric patients all the way down to 3.5 kilos. And so I just wanted to point that out for those that may be in facilities that do have infusion capabilities, that this should be a tool that is considered in the toolbox. Next slide, please. And just some reference websites and resources for further information in terms of coding and reimbursement on this product. Next slide, please. Okay, let's get into the oral antiviral. So we'll start with Paxlovid. So this is obviously a combination product of nirmatrelvir and boosted with ritonavir. This is indicated for adults and pediatric patients down to including age 12 with mild to moderate COVID. Specifically, they have to have a positive test result. This can be a direct antigen, molecular test. Any test will do. The groups that should be targeted for this are those that are at high risk for progression to hospitalization. And as with all of our outpatient therapeutics, it should be initiated as soon as possible after a diagnosis has been made. Also understanding that there's a very narrow treatment window, that it needs to be on board within 5 days of symptom onset. And I think this is probably one of the larger challenges that we all face, understanding that many times we're seeing patients who may be a few days or more into the course of their illness. And also is not recommended in patients with severe renal or hepatic impairment. Clearly, it is not authorized for the treatment of hospitalized patients. However, if you have a patient that was started on this medication in the outpatient setting and then they require hospitalization, we do recommend that they continue and complete that course. It is also not indicated for pre-exposure or post-exposure prophylaxis. And clearly, we do not want it to be used any more than 5 consecutive days. Next slide, please. So I think some of the biggest challenges and precautions with Paxlovid center around the ritonavir and its CYP3A4 interactions, as well as P-glycoprotein. For many frontline providers, myself included, I've never written a prescription for ritonavir. And so this may be relatively easy for infectious disease doctors that take care of some of these populations. I think for many of us in the front lines, in primary care settings, this is difficult. And so understanding that we're all moving very quickly, that this COVID-19 patients are only one of several patients that we're taking care of, patient groups on a daily basis. We're trying to distill the information and make it quick and easy as possible for providers to have resources that they can quickly go to answer the questions, and looking at patients' concurrent medications and seeing if there are concerning drug-drug interactions. So I have highlighted a link to Liverpool has a drug interaction website that is specific to COVID-19, and I found it to be very useful. Hepatotoxicity, obviously, we want to keep an eye on. Keep an eye on transaminase elevations. This has been noticed in a small percentage of patients, and again, associated with ritonavir. There's the theoretical concerns around drug resistance, which again is not specific to this medication, but more to these classes. And then I would just recommend for those who haven't had a chance to look at the NIH guidelines, they are continuing to push out updated guidance on management of these populations, and specifically risk and vulnerable populations. And also they have a very organized tiering in terms of use of the different agents, both oral agents and infusion agents, the data behind those decisions. And then in addition to that, they also do a good job in terms of trying to tier risk groups, both vaccinated and unvaccinated, in our current setting with limited supplies of the therapeutics. Next slide, please. This is just a reflection of the Liverpool. So you can actually put in Paxlovid and click at the top. You can look at specific interactions between a concurrent medication and Paxlovid, or you can put in Paxlovid and hit the view all checker, and you can just run down the list and it will organize by category of concurrent medication. And then it has 4 tiering in terms of risk, whether it's a major contraindicated drug-drug interaction, moderate, mild, or no interaction concern. Next slide, please. So let's get into some of the data. So I know all of you have likely read the EPIC HR trial, which was just recently published in the New England Journal. This was a phase 2/3 double-blinded study of roughly 2,200 non-hospitalized symptomatic adults with lab-confirmed SARS-CoV-2 infection, and they were randomized to receive Paxlovid or placebo within 5 days of symptom onset. This population included one or more risk factors for progression to severe disease as defined by CDC. They were required, none of these individuals had been vaccinated or have had evidence of a prior COVID-19 infection. Standard of care was allowed, but the primary analysis population was limited to individuals who did not receive other therapeutics, including monoclonal antibodies. And the vast majority of the variants identified during the time of this study were Delta. Next slide, please. So looking at efficacy, and I think, many of us, myself included, I love to try to generate number needed to treat to kind of put this in. I think it helps when we're having those risk discussions with our patients and talking about benefit and helps them kind of, it's one way I've found that kind of helps lay individuals better understand kind of our thought process behind utilization of medications and therapeutics and what our endpoints are. And so much of this, when you calculate these numbers and you think about it, I also want to point out that you want to specifically look at what the event rates are, because there are some differences between some of the studies that we'll talk about today. But overall, if you go to the middle column, you'll see a reduction in hospitalization and or death of roughly 6.5%. That puts us in a number needed to treat category somewhere in around 20. Again, I think you also have to keep in mind that we're talking about an unvaccinated population. And also the median age group was somewhat younger than what we'll see when we talk about the molnupiravir studies. But anyway, things to keep in mind. Otherwise, excellent efficacy. 88% relative risk reduction for the primary endpoint, which again puts this agent on par with our monoclonal antibodies in terms of overall efficacy. But it's in a pill and certainly logistically easier to administer. I think, again, the biggest challenge is really getting patients within that 5-day treatment window or sooner if possible. Next slide, please. So just looking at some of the safety data and also some of the anecdotal feedback that we've gotten, GI upset tends to be something that we see more frequently with Paxlovid. Certainly a small number compared to the total, but it is something that I would make patients aware of just so that there are no surprises on that side. Next slide, please. Just to summarize, again, Paxlovid was authorized in the end of December for treatment of mild to moderate COVID, specifically includes pediatric patients down to age 12 who are at high risk for progression. So, how you define that, and I think we need to take into account multiple factors, not the least of which would be vaccination status, understanding that really these agents should not be a replacement for vaccination, and hopefully, a big part of the FDA's approval of vaccines for the pediatric populations were specifically to make them available for those high-risk patients. Again, there was a significant reduction in COVID-related hospitalization and death on par with our best mAbs when given within 5 days of symptom onset, again, in an unvaccinated population, with relatively minor safety concerns. Again, I will say that these patients, if memory serves, the median age was somewhere in the neighborhood of 45. And I believe the over 65 population may have been somewhere in the neighborhood of 13 or 14% of the total study population. Key things to remember would be the drug-drug interactions. And again, for those that are not comfortable or had a significant experience prescribing ritonavir, I would recommend that you look at those drug interaction checker tools. I recommend the Liverpool. There are several out there. Also, this drug is not, there is a reduced dose for those with renal impairment, GFRs between 30 and 60. Pharmacists are pretty good with that, but do understand that in terms of prescribing. And then those with severe renal impairment or hepatic impairment really just don't have enough good data in these groups yet to make these recommendations. I know even an agent like remdesivir, which we do not recommend in dialysis patients, there are nephrologists that are working on protocols. So more to come from this in the future, hopefully. Next slide, please. Let's jump into molnupiravir, so Merck's agent. Next slide. So again, authorized for similar population, but adults only. So those for treatment of mild to moderate coronavirus in adults, so 18 or older, with, again, a positive result, direct antigen or molecular test, who are at high risk for progression to hospitalization and or death, and specifically for those whom other COVID-19 treatment options authorized by the FDA or approved by the FDA are not accessible or clinically appropriate. And just a key on that clinically appropriate. So just to kind of help providers, we've been working with our pharmacy partners to really try to identify how many of my patients, understanding that many of the risk populations I'm trying to identify are older with multiple comorbidities. Some of this data goes back to old data, looking at HIV populations with ritonavir and older patients. Some of this is new data generated from inpatient data. And so, we don't have the ideal data yet. We continue to gather data, but roughly between 5 and 14% of those risk groups I would expect to fall into a potential category of having major or severe drug-drug interactions that might make you reach for another agent. Specific to molnupiravir, the limited authorizations of use, again, this is for adults only, and for good reason. And so it is not for the treatment of patients who are hospitalized, clearly, but also like Paxlovid, if someone was started prior to hospitalization and then progressed, we do recommend that they finish the course of treatment unless they are having a specific complication or adverse event that we think is specific to the agent. We do not recommend, or it is limited for no more than 5 consecutive days. And again, it is not for pre-exposure or post-exposure prophylaxis for prevention. Dosage 800 milligrams taken every 12 hours for 5 days with or without food. And like Paxlovid, we want it to be taken as soon as possible after a diagnosis has been made. And specifically, it has to be within 5 days of symptom onset. Next slide, please. Specific populations of concern. So it's certainly not recommended during pregnancy. We have extremely limited data, if any, really limited to animals at this point. There is a pregnancy watch site set up through FDA and Merck. Obviously, you want to do due diligence in terms of identifying those individuals who may be pregnant or looking at pregnancy in the future. So all individuals of childbearing potential really need to be using effective contraception. So specific to women, this would include the duration of treatment and then a 4-day washout period after the last dose. For males, it's somewhat significantly different in terms of how the germ cells are generated. Their contraception really needs to go for 3 months after the last dose of medication. And so, I think the uptake on that side may be a little bit more difficult. Again, we are hopefully identifying older at-risk individuals and understanding that there are younger individuals at risk as well. But for this agent specifically, I do see that the older population would likely be best suited for its use. Breastfeeding is not not quite done yet. Breastfeeding not recommended, so pump and dump for the course of use, if it will be used, and then 4 days after the last dose of molnupiravir. For pediatrics, because of potential bone growth impact, it is not recommended for those individuals, obviously less than 18 years of age. And then there isn't a dose adjustment specific for renal or hepatic impairment. It's certainly not recommended for those individuals with the most severe hepatic impairment. Correction, we have limited information in that regard, so strike that last comment. In terms of drug interactions, so this is where this agent would shine. So individuals where you may not have Paxlovid, or they have a major severe drug-drug interaction for an agent that's specifically, a cardiac or rhythm agent that may have a very narrow therapeutic index. This would be something that should be considered in the toolbox if other things are not available. Next slide, please. So just touching on the move out trial. So this was a phase 2/3 randomized placebo-controlled double-blinded study to evaluate molnupiravir, that's the parent MOV, in non-hospitalized adults. The upper left-hand corner, we're looking at the phase 2, and that's reflected in the smaller ends and different dosing schedule. And then the lower right-hand corner, we're looking at the phase 3 with the agreed upon dosing of 800 milligrams Q12 times 5 days. Primary endpoint similar to the prior study, with individuals who are hospitalized and or died through 1 month's time. Next slide, please. So eligibility, it's a obviously lab confirmed SARS-CoV-2 infection within 5 days, equal to or less than 5 days prior to randomization. A slightly older age group, those individuals older than 60, with with obviously risk factors for progression to severe disease. Again, this population was unvaccinated, and pregnant individuals were obviously excluded, and contraception was required. Next slide, please. So you'll notice again what I was referring to in terms of the event rates are higher, as you would expect with the older age group. But there was a 3% reduction in terms of hospitalization and or death. So, that certainly puts us at a higher number needed to treat. I think the big question with both of these agents and many of our therapeutics is, when they're designing these studies, to look at, the event rate is key, and it really speaks to the statistics behind the study and the required number of individuals to show statistical difference. And so again, it's certainly understandable that you would use unvaccinated populations to help look at a higher event rate and see if there is a difference between your placebo and treatment groups. However, we know that thankfully the majority of our older at-risk population are vaccinated. And so the question really remains to be seen is, are these, both of these agents, are they effective, and what is that number going forward in not only unvaccinated, but because we have a sense of that, but really the vaccinated populations. Next slide, please. Just touching on some of the AEs, nothing exciting here. Next slide. So just a summary. So molnupiravir, the parent drug, is not authorized for any pediatric agents due to potential effects with bone and cartilage growth. It can be used regardless of vaccination status in adults. Breastfeeding is not recommended. But if we're in that situation and you have a risk benefit that is favorable to use, then again, pump and dump for the course of illness and 4 days after the final dose. The lack of drug interactions recognized to this point is probably one of the shining silver linings to the use of this agent, given its reduced efficacy compared to Paxlovid. And again, there's no dose adjustment in patients with renal or hepatic impairment. Next slide. So with pregnancy, again, not recommended during pregnancy. I think we've kind of made that clear. If you had a very high-risk patient with limited supplies of other agents, clearly, then you want to have an in-depth conversation in terms of risk benefits and answer all of those questions so that we're all on the same page. And then really, I think more for on the practical side for individuals that, may slip up in terms of contraceptive recommendations, particularly on the male side, that there is a pregnancy reporting mechanism in place and that patients are aware of that if that should happen. Next slide, please. Prescriber requirements. So information is key. So make sure that your patients have a copy of the patient fact sheet and that you've reviewed this. This is key for, when patients are between the physician visit and perhaps the nurse follow-up, or whenever you have that time slot where patients can kind of go through this information and then touch base with you once more so that you can kind of answer any questions that they may have specifically. Obviously, assessment of childbearing potential is key, and contraceptive use, obviously. And that information, again, needs to be clear with those appropriate patients. Also make them understand that there is a surveillance program and that all medication, AEs, they could certainly, there's a mechanism for patients to report, but it's best just to touch base with their providers if they're having any adverse events or concerns related to the medication. Next slide, please. So again, many of the questions that I've received have centered around the theoretical risks of mutagenicity with molnupiravir. And so as with all the agents that we give to patients or prescribe, there's always should be a robust risk-benefit conversation and discussion. I think that, the historical paternalism that may have existed back in the beginning of my medical training has rapidly kind of gone away. I know that providers have their individual prejudices with certain medications, but I also think that I hope that these conversations with molnupiravir would be had with patients if there was no other treatment modality available for their COVID-19 and they were, an appropriate patient in terms of having multiple risk factors for progression to hospitalization. With ribonucleotide reductase, we know that there is a metabolic pathway for the potential for mutagenic analogs within DNA synthesis. We understand this. With our, eukaryotic mechanisms, there are multiple repair mechanisms in place. Understand, I don't mean to make light of molnupiravir, but we are exposed to mutagens and carcinogens on a daily basis. But again, the lack of data in this regard, their unknowns, and the limited efficacy for those that attended the pre-FDA meeting of experts, we know that it was a very divided vote, and there were even some suggestions that should other agents come on the market, that this EUA, there was a question of if it would be revoked due to its limited efficacy and considerable theoretical risk. So I think that's still on the table. Just wanted to touch base. I did follow up with some of my non-clinical colleagues in terms of the sequence of test results. So the summary of this, looking at, so the MOV would be the parent compound and NHC would be N-hydroxycytidine, looking at the doses that they used. And so, a total daily dose exposure, 600 milligrams over a 24-hour period, looking at what was tested, specifically the in vitro data, there was roughly a 3 to 6-fold higher doses used, which revealed negative mutagenic tests. Clearly, we're watching this closely, but I also think that, it also touches on what is exposure, and it's not just the specific agent or a concentration, but also the time frame of exposure. And so I think that, the limited 5-day exposure weighs heavily into, how far we take these tests. I also think that I and myself included, I would be somewhat reluctant to use this in a patient that is a younger individual. Understanding the potential theoretical risks these mechanisms And again, hopefully those individuals, what we can answer is, how effective is it in the vaccinated population? But I think we all understand that, if we have a number needed to treat based on event rates in vaccinated versus unvaccinated population, a number needed to treat of 20 to 30 probably drops to somewhere between 120 to 160 or higher in a vaccinated population. And so I'm hoping that the majority of these individuals, regardless of their age, are vaccinated for that reason. So certainly viral evolution in immunocompromised populations, we know that they can shed for several months. And so I think that that's an ongoing concern, not specific to molnupiravir, but all potential nucleotide agents. And then again, for that older individual where there's nothing else available and may have a major contraindication with a concurrent medication that can't be really held with Paxlovid, I think across the board, probably 10% is a good estimate for these populations. But also it comes down to provider comfort level. There are some medications where we can look at dose adjustment. I think the FDA is very clear with this. We're looking at pushing out more information, and both IDSA and NIH guidelines panel have also put forth excellent documents on this. Next slide, please. Just some reference information that is available from Merck on molnupiravir. And again, this will be obviously in our slide deck and available to all that would like to have it. Next slide. Just some of our ASPR resources. We're continually working on new clinical guidance material in addition to updating our, some of our existing tools. Next slide. Therapeutics locators. So we've finally gotten all of our therapeutics under one roof in terms of our new locator site. And that will include both sotrovimab, which has recently been migrated into that system, and bebtelovimab. And also for those interested to look at what the allocations are specific to their state or territory, we have that information that's pushed out weekly. Next slide. Our announcements, just some more resources for those interested in terms of reimbursement questions. Next slide. Some of our stakeholder engagements that those you're certainly welcome to attend. We have I have my two major stakeholder calls on Wednesday, one for state and territorial health officials, but the 3:15 p.m. Eastern time is really for national healthcare and medical organizations that I know some of you have attended in the past. Next slide. And just again, some of the clinical tools that we've talked about. There's also reimbursement information, CMS toolkit website, and some more information for those interested in some of the HRSA, if you want to look specifically at where those F2HCs may be within your state or territory. Next slide. All right, I appreciate it, and thanks for your attention, and wanted to leave as much time as possible for our Q&A session. Cheers.
Great. Thank you very much for that presentation. Super thorough, very interesting. Thank you. We have some questions from participants. Let me get started on those. Actually, a relatively quick one. The patient handouts for the oral agents, I think the links to those were in the presentation, right? So
yes, sir. Yes, sir.
Okay, good. And the slides will be made available to anybody who participates. There'll be a link to get the slide set. And I think you could probably just Google patient fact sheet Paxlovid and be able to probably find something on the internet, but the official ones, the links will be in the.
Yeah, I'll add that we have weekly meetings with all of our pharmacy partners, including Merck and Pfizer. And so we are pushing them to leverage their advertising assets, which are considerable, as you would know. But they're really doing a good job in terms of working on PDF, very like 2-page patient information sheets that providers can use as a discussion piece to kind of go over a lot of the key questions. And so I've met with both groups just recently, and they should have that material out shortly. So just continue, along those lines of Googling, just continue to follow up with the manufacturer sites as well.
Great, thank you. I know that with the EPIC HR study of Paxlovid, the patients were unvaccinated, and a lot of the information we're getting, at least in California, from the State Department of Public Health and our county departments are to use the medications in unvaccinated patients. Is there much data about their use in high risk but vaccinated patients? Is that something that you think is going to change over time, or is there not enough benefit? The vaccine protects them enough?
Yeah, I mean, I think that's a great question, Joe, because if you look at looking at CDC sites in terms of their data, their weekly data on hospitalizations, it's very interesting. They actually break it out by vaccine status. And as we get older, in those older populations, clearly related to multiple comorbidities, a simple cold, as many of us have experienced, can place many of these patients in the hospital and at risk of death. And that's what we're seeing, still significant numbers in the vaccinated populations, understanding that vaccines are still the foundation of our response. But I agree, and I think it really comes down to the availability of the product, and knowing that, again, as we move into April and May, the supply of Paxlovid will go up considerably. I believe we're getting somewhere in the neighborhood of over 2 million courses in the month of May. So expect to see those supplies increase. And part of my priority is really to help providers try to avoid the potential landmines with the drug-drug interactions and Paxlovid. So even if it's something simple like letting patients know, let's say you're on an SSRI, and some of the symptoms that you had when I first put you on that, the akathisias, the tremors, the shakiness, whatever, you might see a little bit of that. You might see a little bit you might be a little bit more sedated. So just kind of be aware of all of those potential symptoms, but also understanding that this is a very short course. And I think for the vast majority of patients, it shouldn't be a significant issue. But I also would just, again, foot stomp that providers need to do their due diligence and really try to make use of those drug-drug interaction checkers to make sure that you don't, especially your cardiac patients, that, there isn't something potentially dangerous that might happen.
Yeah, I think those tools are going to be key. I think a lot of times we will rely on the patient's pharmacy as well. They know the medicines that are on, and occasionally I'll get a call from a pharmacy when I prescribe something and didn't anticipate an interaction. The pharmacy said, "Hey, look, we screened it, and this is an interaction." Hopefully that will occur as a secondary check. I guess one of the concerns would be, because the medicines are only going to some pharmacies, an individual may not go to their usual pharmacy. Do you know if, let's say I always go to one pharmacy, and then to get my prescription for Paxlovid, I go to a different one, do they necessarily know the medicines I'm taking to be able to run their check?
So again, if you're talking about a major chain, I believe all, if not most of the major chains have their computer systems linked, but it's a great question. What if I'm outside of, if it's at a CVS and I normally go to Walgreens? And so, I think it's key that there's continuity and that information gets relayed. Part of the concerns and pushback that we've gotten from pharmacies, and it's really at the point of, some of the pharmacies potentially dropping out, and definitely, at the top of our lessons learned would be that pharmacists are not getting really acceptable dispensing fees back for the work that they're doing. And so, some of the dispensing fees are on the neighborhood of less than $1, which is just kind of a typical dispensing fee. If you look at something like ritonavir, would be, $15 to $20 or potentially more, just based on the workload involved. And so I think our pharmacists, it's team, but our pharmacists clearly appreciate providers kind of doing their part and trying to kind of screen out these medications whenever possible.
Another question about interactions. A lot of the focus seems to be on the Paxlovid and the cytochrome pathway, and that affecting medicines that a patient's already taking. There are some CYP3A inducers that a patient might be on. There are not that many of some of the older seizure medicines or rifampin that could affect the metabolism of Paxlovid and make its components be metabolized more quickly. What's the therapeutic window with that? Is there any anticipated dosage change, or does a person need to stop their CYP3A inducer if they were taking one of those and needed to take Paxlovid?
Yeah, no, it's a tough question because some of these, like you mentioned, some good possibilities, phenytoin, carbamazepine, phenobarb, some of
Mhm.
these agents for some patients, just it may not be, the provider may be opening a larger can of worms in terms of the risks of stopping those medications. And so the other problem is that that even with a reduced dose, you still run the risk of making the Paxlovid inefficacious because of reduced serum levels. And so I think it's difficult. Again, we're trying to distill that, knowing that, if a lot of providers, because of the pace we're made to move at on a regular basis, you provide too much information, you might just get people that they just tune it out really and say, I'm gonna rely on the pharmacists to kind of do their thing, and then they can call me if they have concerns. And so I think some of the cardiac agents, the sodium channel blockers, some of the dirty drugs, and I say dirty like amiodarone, not that I don't use amiodarone, but it's just multiple mechanisms of action that can run into issues. Some of the medications that have QT prolongation, it might make sense if you don't have a recent EKG on file to just kind of document that and see. But then the larger question is, a provider might say, okay, Dr. Eisnor, I had a QTC of 460 and now I'm at 510. What should I do? Should I do anything in this regard? And you're 3 or 4 days into the course of the illness. And so, many questions, but I think, again, we're doing what we can to kind of distill that down. And I would, for those, again, that haven't prescribed this, which I think is most of us, use those drug interaction checkers, have the conversation with the patient, and then decide, Paxlovid may not be the drug for you because of concurrent medications and the risks of holding some of those medicines.
Mm-hmm. Got another question. Is there any reason to question the efficacy of Paxlovid or molnupiravir even with Omicron and the BA.2 variant when the studies of their efficacy were done with Delta? Is there anticipated to be a big difference in efficacy because of the variants?
Yeah, great question. So in vitro and animal studies have shown that they're still, highly efficacious. We obviously are very interested in real world evidence on all of our therapeutics because, again, many of them, especially the recent, we've had a slew of recently authorized agents that were really tested pre-Omicron. And so, we certainly have, and the companies are required, in addition to some of our private and non-public partners have done the studies to look at in vitro as quickly as possible. And again, our best indication is that they maintain efficacy. One of the big questions was really, and continues to be, is the FDA guidance on bebtelovimab, the recent EUA, in terms of why is that ranked down on the list in terms of priorities. And I think, we would all know that it's limited to the lack of clinical efficacy data, but our in vitro data shows that it's excellent against Omicron and all subvariants. So hopefully, as we garner more real world evidence, that bebtelovimab can be put on an equal footing with something like sotrovimab.
Mm-hmm. Great. I think the answer to this probably lies in risk stratification and maybe checking some lab work. But the question is, what do you suggest if Paxlovid is your only choice and you don't know the patient's GFR status?
I think, again, you would want to, it really would based on your clinical suspicion. So if you have a patient that has a baseline study, in the last 6 months that they're in a good spot and you have no reason to believe clinically that they've had any change in that regard, then I think you use your clinical gestalt.
Mm-hmm. Great. And then a couple questions about whether these medications may be available for urgent cares to dispense in their offices or in their practices. What's any news on the status of that? The logistics and mechanics.
Yeah, great question. And I think those sites that are interested in doing that really get together with your Department of Health officials who basically are making the determination of where product goes and how much of that product goes. And so if you're a specific rural area and you have the capability to do this, and understanding that there's different rules and regulations specific to states in terms of dispensing and who you have on site, whether you have pharmacy background. I know that, we ran into this with some of the HRSA sites where they may not have had a pharmacist on site, but they have kind of a hub and spoke model where they could have a teleconference with a pharmacist in real time and kind of review any questions, any concerns the patient may have, and obviously make sure that their documentation is up to regulation standards. So I think it's great. I think you reach out to your state planners in that regard and then work through whatever the specific regulations may be.
Mm-hmm. You may not know the answer to this one because it sounds like a little more mechanical question, but somebody's noting that there's a daily reporting requirement when you're dispensing in that situation. And the question is, what system is used to report? And is there a possibility that the current daily reporting may change to weekly reporting?
Yeah, good question. And we continue to get that feedback, understanding that daily reporting, particularly for busy clinicians, can be somewhat onerous. And that's certainly something that we don't want to do. So for everything except for the legacy MAB, which would include Sotrovimab, which is on a weekly reporting schedule through the older legacy system, reporting for all the newer agents, including the oral antivirals, is through HPOP. And that data is key because that feeds into not only Tiberius, which is our kind of but our utilization kind of data that we look at, and also that our states and jurisdictional partners can look at, and they use that to kind of help determine where to push product. But it also feeds into our locator in terms of making sure that those supplies are updated for both providers and the public. I mean, it's a public-facing website. We continually talk about moving to a weekly reporting schedule that's been on the table. Also understand that our utilization reporting is only roughly 60% across the board when you look at that, because we've never, we talk about hard tying that utilization reporting to ordering, but we haven't really pulled that trigger yet. And I think there are obvious concerns. We certainly don't want to stranglehold supplies because of a reporting issue. But with the new Tiberius system, looking at allocation and orders and utilization data, states actually have the capability to look at the sites that are not reporting, those that may be lagging behind. And so we're hoping that there's good communication between the state planners and the individual sites, not only just to kind of work through those potential issues, but also to potentially provide support where it may be needed.
Mm-hmm. Sounds good. A lot of urgent cares are used to dispensing medications at this point. Do you know whether if an urgent care got into the dispensing for these meds, whether they would they be obligated to fill it for somebody outside of their own practice, like become a pharmacy, let's say, for people bringing prescriptions in who weren't seen there? Do you know anything about that?
Yeah, I mean, my understanding from most of the urgent cares, and correct me if I'm off base here, but a patient that walks in with a prescription and you have dispensing on site, I mean, I'm assuming that you're going to require that individual to have an in-depth assessment and at least be seen by a provider and have that done. And so I think if the patient is willing in that setting, unless you are in a rural area where you have maybe a family practitioner down the road that, you have a good relationship with and you've communicated with, I think it really depends on the specific circumstance. As providers, we don't want to create barriers. The pharmacists are instructed that they are to take out of state prescriptions. And for those states that are on the border of Canada and Mexico, they're actually instructed to take valid prescriptions from those individuals who may be residing outside the US as well. So I think the key is we don't want to create system barriers to access. And so, the first thing I would do is probably have a conversation with that prescriber if it's someone that I didn't know or already kind of have an arrangement with, if that makes sense.
Mm-hmm. Great. Another question about the mutagenic mechanism of action for MALDU. Is there, if you think about what's kind of maybe slowed us down in terms of getting ahead of the COVID pandemic, it's been the kind of natural mutation of the virus over time. And I understand that the mechanism of action is to induce mutations which make any new RNA non-viable. Is there something about its mechanism of action that sort of guarantees that, or could now something making it mutate more frequently? If 1 million people were to take molnupiravir, let's say, in the next 10 months, would there be more potential for variants? Is that a concern at all? I mean, not just the mutations in the patient's body, but mutations in the virus making it more trouble to deal with because now variants are coming about more often.
Yeah, it's a great question. I think the theoretical concern is always there based on those mechanisms. I would say based on the short course of exposure, but really more the level of mutagenesis. So this agent typically induces hundreds of mutations within the strain. And so that level of mutagenesis, I think there's less of a chance that you're going to have a surviving potential subvariant or mutation. But again, it's a great question, and I think it's something we need to continue to look for.
Yeah, great. There's a follow-up on the dispensing. So let's say you had that patient that came in with a prescription from outside. So the question is, what if the patient refuses to be seen? Would you think you would have to dispense to them?
Yeah, it's a tough question.
I know.
I think it depends on where you are, really.
Yeah.
I mean, if you're out, I've been some of the areas of rural Montana. If you're on the wrong side of Yellowstone, there may be nothing else available. And so, I think if you're in a setting where there are pharmacies available and you've kind of confirmed that with the locator, I think it gives you more options, and staying kind of, you're still ethically within bounds. But I would, I think, it's a tough question. I think if you're in a setting where you're the only show in town, and specifically you don't want to delay, and maybe they're on day 4 or day 5 of their illness, then I think you got to ultimately, we all make the best decisions for what we think is best for our patients. And so, yeah. Hope that helps.
Yeah. You talked about the kind of low dispensing fee, I think in one context. Do you know, is that low dispensing fee what an urgent care would expect to get with that $1, I think you said, for Paxlovid, or is that?
Yeah. So that's part of the problem. And I think that's why, I could certainly see providers, but, there's also safety concerns as well. And if this is someone walking in the door who's never been in your practice, you want to do a thorough assessment of that individual. But certainly if you have a provider fee that's rolled into that, then, you can certainly, that can offset and subsidize a lot of those costs. Our initial thought, and we were just off base with this, was that, come on, dispensing fees, we're talking about $10, $15, $20, for the most part. The Part D payer, we're in a pandemic, Part D payers will step up. This shouldn't be an issue. And also, for those that may be unaware, like there are severe legal implications if CMS tries to kind of throw its weight around. They are really not allowed. They can kind of set, so for those that don't have the Advantage plan and have just the Medicare plan, or even Medicaid patients, they've really set the tone, and they have a reasonable dispensing fee. If you look at the HRSA coverage of the uninsured, dispensing fee somewhere between $10 and $12, but they are really not allowed legally to say, to really kind of suggest or make a strong influence to those Part D payers and say, we expect you to do this. They just can't. Hopefully, we were hoping that they would just kind of follow by lead. But this continues to be an ongoing problem. And again, we're at the point where some of the smaller pharmacies are like, I don't want your product. I'm refusing it. And so a big concern on our side, and obviously with our jurisdictional planners.
Great. Thank you. I think actually we're just about at the end of our hour, and looks like we've addressed all the questions. Yeah. Well, thank you very much for the presentation and the Q&A. We really appreciate it. In terms of our next town hall, we don't have anything in the works yet, but we will be working on new education for everyone. Thank you, everyone. Stay safe,
And
be well.
appreciate the opportunity. Thank you, Joe, and thank you all.
very much. All right, take care.
Cheers.
Yep, bye-bye.